So, good morning, everyone. Today we will continue with our journal club with Dr. Sarah. She will talk to us about systemic manifestations of tuberous sclerosis.
أجينا له هنا أحسن هنا أحسن
لا keep you حتى
Good morning everyone. Our seminar today is about tuberous sclerosis supervised by Dr. Ahmed Abdulwahab. First I will talk about introduction of tuberous sclerosis. Tuberous sclerosis is neurocutaneous, autosomal dominant neurocutaneous disease characterized by multiple hematomatous lesions occur in different parts of the body, affect both sex and all ethnic groups. The prognosis is bad. Most of the cases are die at the age of 35 years. They pass away. Tuberous sclerosis has a trait. The trait is epilepsy, mental retardation, and adenoma sebaceum. But this trait is not necessary to appear in all the cases of tuberous sclerosis. Most of the cases, half of them, they have normal they do not have mental retardation, and quarter of them have no epilepsy. We have some major and minor criteria for tuberous sclerosis. Each of these criteria is divided into frequent and common and common. For the diagnosis, for definite diagnosis of tuberous sclerosis, it's a must. We should have two major or one major, two minor criteria. I will talk about some of these criteria here, then I will talk about radiological manifestation in each of these criteria. Just I want to tell you that there is some criteria. If they are occur both together, we consider it one. For example, tuberous sclerosis with white matter radiating bands, they are considered to be one criteria. And every patient with lymphangio and renal angiomyel should have another criteria for the diagnosis of tuberous sclerosis. These are frequent criteria. Hypopigmented macule and facial angiomyelite angiofibroma, these are two major frequent criteria. And multiple bits of dental enamel is frequent minor criteria. Common major. The common major include retinal hamartoma, rhabdomyoma, renal angiomyolipoma, lymphangio. These are common major. And common minor include bone cyst, renal cyst, gingival fibroma, and also white matter, radial white matter band also is one of the minor common criteria. I will shift to dermatological manifestation of tuberous sclerosis. It includes hypopigmented macule and facial angiofibroma. These are two major criteria which appear in 90% of cases with tuberous sclerosis. And we have another uncommon manifestation like chagrin patches and angual angiofibroma. These are nodules appear under the nail of finger and toe. Chagrin is white or grayish patches, brown patches appear in the lumbosacral area. Neurological manifestation. I will start from the commonest, which is tuberous sclerosis, then subepidermal nodule, white matter change, and giant cell astrocytoma, subepidermal giant cell astrocytoma. Giant cell astrocytoma is not necessary to appear in all cases of tuberous sclerosis. I will start with cortical tuberous. Cortical tuberous is due to destruction of normal 6-layer of cortex replaced by dystrophic neurons or astrocyte. These are more commonly appear in parietal and frontal area. If it's occur in parietal and frontal, it's associated with autism. It's appear hypo on T1, hyper on T2, and 10% of them are post-contrast enhanced. In T1, the periphery of the lesion is either to gray matter and the center of the lesion is either to the white matter. But we have one problem in neonate. In neonate, this lesion, most of them are skewed, not appear in T2, it's more appear in T1 because of demyelination. They are
Because the neonate normally have a demyelinated brain, still no myelin form.
So it appear more obvious on T1, not in T2.
And the cortical tubers, they are not tumors.
Yeah.
They are just disarranged layers.
Yeah,
It's a dystrophy.
destruction of the layer.
Dystrophy, not destruction. Dystrophy. That is normal tissue and abnormal arrangement. Okay?
Replaced by neuron and astrocytoma.
Exactly.
Subepidermal nodule, these are nodules, hamartomatous nodule, appear near the lateral ventricles. These nodules, some of the authors that say that the number of the nodules is not related to the disease, but because of the size and involvement of this nodule are important for the surgical management, so we will do CT and MRI for them. These subepidermal nodules, sometimes it's difficult to be differentiated from the giant cell astrocytoma, but the giant cell astrocytoma usually occur near the foramen of Monro and cause obstruction. That cause obstructive hydrocephalus. But sometimes these nodules are also, giant cell is also larger than the subepidermal nodule. Giant cell astrocytoma, the subepidermal nodules sometimes become large and appear near the foramen of Monro, so it cause same change. We can differentiate them only by MR spectroscopy. That in giant cell astrocytoma there is high choline-creatinine ratio and low N-acetyl aspartate creatinine aspartate with choline ratio. This is subepidermal giant cell astrocytoma. Axial, it's more calcified lesion, so we can diagnose it better by CT and also by MRI it appear hyper.
So, show it to them.
This lesion.
The
Near the
whole
foramen.
thing. All of it.
This is all?
Yes. It's
And this is the calcification.
Giant cell astrocytoma. It's not only microscopic by vision.
Yeah.
It's big, should be.
And this is the calcification
Yeah.
with this inside. White matter bands. These are curvilinear bands that appear more obvious on T2. White matter radiating bands. This is also one of the white matter changes occur in tuberous sclerosis, but it has a good prognosis. White matter cystic change, this is due to degeneration of the white matter or due to blood vessels, dilatation of blood vessels. Perivascular dilatation filled with CSF fluid. It has the same CSF signal intensity in both T1 and T2, hypo in T1 and hyper in T2. This is also, it has no any clinical manifestation and no treatment. Cardiac manifestation include rhabdomyosarcoma. The rhabdomyoma can be diagnosed neonatally, in the fetal life. Antenatally. Or can be diagnosed after birth, but some of them are resolved at the age of 4 years. But and cause no any sign and symptoms, asymptomatic. The patient, they are asymptomatic. When it causes symptom, it can cause arrhythmia and cardiac failure. When the patient has symptoms, it needs surgical repair. Pulmonary manifestation of tuberous sclerosis. The pulmonary manifestation characterized by multiple cystic change, symmetrical in both lung. These cysts are connected to the airway, and we prove it by changing its size during expiration in the CT.
What's this called? What is this called?
Lymphangio-myomatosis.
Only in the female.
And
It's exclusively occurring female.
so keep in mind, lymphangio means vessels of lymph, lymphatic vessels. Lymphangio. Myo means muscle. So lymphatic vessels and muscle myomatosis, like proliferation. It's just due to proliferation of the lymph vessels and the smooth muscles. Okay? It's exclusively in male. When you have a male patient, in female, sorry. When you have a male patient with this appearance, you never ever say lymphangio. It's not possible. Just female. Lucky for us, huh?
I will stay here, it's better. طبعا for the lung manifestation we have two diseases, lymphangio and multifocal micronodular pulmonary hyperplasia. This disease is uncommon and the name was changed because the new name is more descriptive. The new name is called, it's a very difficult name, atypical adenocarcinoma of epithelium. Adenomatum of the epithelium. This is more descriptive name. I don't know.
It's multiple nodules and tiny nodules.
Tiny nodules, yeah. But I cannot see these nodules here.
You cannot see them?
No.
All of it. See.
Where is it?
This one, this one, this one,
Oh,
this
but
one,
these
this
are
one, this
on
one,
the
this one,
nodule.
this one, this one, this one, this one, this one, this one. All the white dots are hemocyte.
Can I see this because there is some information I missed?
Sure.
Okay.
No problem.
Before we shift to this disease, we are in the pulmonary lymphangioleiomyomatosis. The main complication of pulmonary lymphangioleiomyomatosis is pneumothorax, sometimes chylothorax, which leading to the respiratory failure. This chylothorax is due to chylic leak and oozing from the lymphatics. It is treated by pleurodesis.
They fuse the parietal
Yes, to
and
the
the
chest
distal
wall.
pleura. Exactly.
To the chest wall, but sometimes it causes problem during lung transplantation because it forms adhesion.
Why do we have chylus?
Due to a lymphatic obstruction.
Because we said lymph angio.
Angio.
The lymph is abdominal. Good.
Okay. And we said there's complication with the airway. The other disease is lymphangio, is multifocal micronodular pulmonary hyperplasia. As I said, they changed its name because the other name is more descriptive, and this disease is it is 1 to 8 millim nodule scattered appear in all the lung parenchyma, and also it needs no treatment. Sometimes it's difficult to differentiate it from granulomatous or from the metastasis, but as it is associated with tuberous sclerosis, it is diagnostic for this disease.
Okay. What if we don't have tuberous sclerosis? This appearance what's the differential of this appearance? Miliary TB. And miliary metastasis. From where miliary metastasis? First of all, thyroid. أول شيء thyroid. Miliary metastasis. Okay, good. Thank you.
Renal and retroperitoneal manifestation. Renal include renal angiomyolipoma, renal multiple cyst, and renal cell carcinoma. But the renal cell carcinoma is not common. It's not common. And in the retroperitoneum cause retroperitoneal lymphangioleiomyomatosis. First, I will talk about renal angiomyolipoma. Angiomyolipoma is an echogenic lesion. It's a lesion in the echogenic in ultrasound that contain numbers of blood vessels, smooth muscle, and fat. Because of its containing fat, so we use CT most commonly for the diagnosis. In CT, it appears hypodense, and it sometimes contain calcification. But there's a problem. Some of these angiomyolipoma, it's lipid poor. So where we will mix it with renal cell carcinoma if it's lipid poor. How we know that this angiomyolipoma is lipid poor? It's appear hyper on CT, appear hypo on T2 on T2, and ISO on ultrasound. In these cases, we will mix it with renal cell carcinoma, and the most important complication of angiomyolipoma is rupture. When it's ruptured, we will find blood in the renal, in the retroperitoneum, and perirenal area. But if this fat during bleeding is obscured by the blood, it's also mixed with ruptured renal cell carcinoma.
Advice, everywhere, every time you say renal cell carcinoma, all patients, always, when you say renal cell carcinoma, or,
Angiomyel.
لا oncocytoma.
Oncocytoma.
دائما
Yeah.
من تقولي رينال سيل كارسينوما طبعا الكل سواء تيوبرس مو تيوبرس ما ادري شنو anything whenever you write renal cell carcinoma / oncocytoma they cannot be differentiated. اوكي الا histopathology. طبعا ruptured angiomyeloma هذا يعني emergency severe bleeding يعني لو تلحق عليه لو ما تلحق. And usually they are big angiomyelipomas rupture مو من 1 centimeter 4 or 5 centimeter and more. لا شنو؟ لا you can't. It cannot be differentiated.
طبعا in such case we will use biphasic CT, venous and arterial phase. Another manifestation or renal cyst, which is multiple renal cyst, as we see in most of the cases. It's also sometimes it causes hypertension. It's another, and it's not dangerous. Renal cell carcinoma is rare manifestation of tuberous sclerosis, but we have the appearance of renal cell carcinoma is different according to its cell type. We have different type of renal cell carcinoma, small cell carcinoma, chromophobe, and papillary. The papillary one is mixed with angiomyelopathy. Clear cell carcinoma, chromophobe, and papillary. How we differentiate these type of renal cell carcinoma by CT. Clear cell carcinoma, it enhances heterogeneously and early washout. The chromophobe, heterogeneous, enhanced early and early washout. The other one, the last one, which is papillary, mixed with angiomyelopathy, it's difficult to be differentiated from angiomyelopathy. If by biopsy, you can differentiate. Retroperitoneal lymphangio, the content of the retroperitoneal lymphangio is similar to that of chylothorax in the chest by cytology. But the cause is due to multiple cystic, thin wall cystic lesion due to lymphatic obstruction, contain lymph in retroperitoneum. When it ruptures, this lymph is spread in the retroperitoneal area. Then we have a differential diagnosis, which is lymphangioma. But when the patient is diagnosed with tuberous sclerosis, the diagnosis will shift to retroperitoneal lymphangiomyomatosis. Other rare manifestation of tuberous sclerosis include multiple polyps. This is renal cyst. This is renal cell carcinoma. Retroperitoneal lymphangiomyoma. Multiple cystic lesion.
Filled with chiles. When they rupture, it will be like chyloperitoneo.
Yeah. And this is miscellaneous abdominal involvement. The most common one is polyp, intestinal polyp. This polyp is appear from the esophagus to the rectum. And we have, of course, another very rare manifestations, which are ulcer, intestinal fibers, leiomyoma, AV malformation, and even pancreas is involved and cause islet cell tumor and hypoplasia of pancreas. Skeletal manifestation. The skeletal manifestation, we have hyperestosis of inner wall of the skull, and we have periosteal newborn formation, multiple osteoblastic lesion. This lesion is occur in all the part of the body, in all the bones, even involving hand and foot. And also we have scoliosis. It causes scoliosis. What do we have else? I think nothing else. By the X-ray, these lesions that appear in the cortex and medullary usually appear as a hypoechoic center surrounded by a sclerotic lesion.
Sorry,
Hypodense lesion and surrounded by sclerotic margin.
Okay.
Main cause of death in patients with tuberous sclerosis. The cause of death is arranged according to the age. In the very young, from 0 to 9 years, is due to cardiovascular. From 9 to 20 is due to status epilepticus. Then is the others is most commonly due to renal failure. The other eggs. And thank you. This is quiz.
يلا شباب منو؟ What do you think is going on here? This is a lesion. Where? Bill, lateral ventricle. It's close to where? It's intraventricular or traverenchymal? Huh? Intraventricular. Close to where? Foramen of Monro. Excellent. It is on. This is what? What's this sequence?
This
T1 لو T2 لو شنو؟
T1.
شو تقولين؟
T1.
This is a flare. Exactly. What's this? This is flare. This is T1 with contrast. So it is. And what's going on here? This is what's this called? This is spectroscopy. This is a flare, not T1. This is T2 with suppression of CSF. هذا T2, هذا T1 with contrast. Okay? So it is enhancing. نجي على السبكتروسكوبي. أي أحد عنده أي معلومات عن السبكتروسكوبي؟ What do we see? What do we look for? واحد. Parween.
A line is going up like the creatinine ratio and
We have three peaks.
choline, yes.
Choline, creatinine, and NAA. And aspartate. Sorry. Okay. This one represent neurocyte. Okay. اليوم عندنا محاضرة حلوة على السبكتروسكوب موجودة على اليوتيوب إذا تحبون تشوفوها. This one represent neurocyte. This one is fixed, creatinine. This one represent proliferation or metabolism. Okay, proliferation. Okay. So when the NAA is down means what? This is fixed. We compare to the creatinine. So when the NAA is less, this means loss of neurocyte. Okay? No neurons. While this is the choline high means proliferation. Okay? So we have a lesion near the foramen of Monro. That is on T2 it is ISO2 slightly hyperintense, enhancing on T1 with loss of NAA and high choline. This means what? In a lecture about tuberous sclerosis. هذا هم بين الهند. So this is giant cell astrocytoma, not subepidermal nodules. Subepidermal nodules are different. Okay? The location, the number, the shape, the signal intensity, all of them are different.
They are hamartomatous.
They are hamartomatous.
It's the same cell.
Okay,
so they
exactly.
will not change.
Okay? تهنى لو. هو شنو هو الفلير؟